The broadcast is now starting. All attendees are in listen-only mode.
Hello, thank you for joining us today for our webinar. My name is Carmen Boone, and I'm an education coordinator from Oregon Pacific Area Health Education Center, a hosting agency of Samaritan Lebanon Community Hospital. Our agency mission is to promote quality health through community and outreach. There we go. And today, I'm happy to be your host and moderator. Let's go over some housekeeping items. On your GoToWebinar control panel, you will notice that all microphones are muted. They'll remain muted during this session. If you are experiencing audio difficulties, make sure your computer speaker volume is turned up or use the phone option to listen in. You may download today's slides from the handout menu. Send us an email request if you have any problem. Use the questions menu for typing questions or comments at any time. We will be monitoring it. The webinar is being recorded and will be available on our YouTube channel. If you have any questions, please send me an email to the email address that you see in front of you of the screen. To obtain credit or a certificate of attendance for this activity, you must log into www.eeds.com and enter this activity code. Please write it down for your records. Consider that the activity code expires in 1 week, so you have 1 week to claim your certificate. We will email you these instructions today, about 2 hours after the webinar. This presentation is jointly provided by the National AHEC Organization, the American Cancer Society, Samaritan Health Services, and the Oregon Pacific Area Health Education Center. The presenters and planners of this event report that we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. This webinar is presented by Dr. Pat Hagerty. He is a dentistry practitioner in Albany, Oregon, born and raised in Albany, and he started practicing in 1986. He is affiliated with OHSU, and his expertise in implant dentistry has made him one of the most sought-after dentists in the state. In his free time, Dr. Hagerty enjoys cooking, skiing, and fishing. And now, without further ado, I will leave you with Dr. Hagerty.
Thank you, Carmen. Welcome, everyone, to the third iteration of You Are the Key dental version. And as we go through the program today, I think you'll see very clearly that you are the key, and that dentistry has a key role to play in the prevention of HPV-mediated cancers. We're going to go into it in some detail. There'll be a number of pearls as we go along, and I would hope to remember to point them out as we go. I think they'll be pretty obvious. Objectives. Describe why HPV vaccination is important for cancer prevention. And here's your first pearl, line number 1, and what that represents. Cancer prevention. All of us have read about, well, we need to cure cancer. Let's raise some money. Let's dedicate our time and resources to curing cancer. Why don't we just prevent it to begin with? And that is the point of this whole webinar today, is that dentistry plays a part in preventing this cancer. We're talking specifically about oropharyngeal, but when one is vaccinated for HPV, there are a multitude of other cancers, other body parts, if you will, that are protected. We're going to look at a case right off the bat of someone who has an HPV-mediated oropharyngeal squame. We'll talk about an exam. One of the things that I think is important, you'll see how the rates of oropharyngeal cancer, HPV-mediated type, have exploded nationwide. We'll get into the details of that later on. This is going to show up in your office. One summer a few years ago, we had 4 men come in about a 2-month period of time, oropharyngeal cancers. It is out there. We need to be looking for it, but we also have to have the systems in place with our staff, with our team. We see something, we need to act. Is it a referral to the local ENT or our normal referral patterns to OMS, oral maxillofacial surgeon? Have those conversations, those discussions before you find the first one, because you will find one. How is it handled? How does the staff react? I've been involved in offices where an employee just lost it, and maybe that's not appropriate for the patient's best outcome and pursuit of ultimate care. So have that discussion ahead of time. We're going to look at the vaccination schedules based on age. We're going to look at the effect of the HPV vaccination on that age group of 11 and 12, where you get the most robust reaction from the vaccination. Self-efficacy in delivering effective HPV vaccination recommendations. Do you know what you're talking about? Do you believe it yourself? Do you understand it? Maybe is a better way to say it. How to do it in a confident, concise response, with concise responses to parents. And then we'll touch on vaccination delivery. As you know, dentists in the state of Oregon can now administer any vaccine. We'll touch on that. By no means is this anything that would give someone the CE necessary as part of a vaccination endorsement in your license. Pardon me while I search for my mouse. My cursor. Great. Understanding the burden, HPV infection and disease, just the burden of disease that is out there of the virus, and then in the accompanying disease levels from that burden. As I said, starting out, we're going to look at a case here. And so this is your first warning. I'll show some photographs, some x-rays, CT scans specifically, and then I'm going to show photographs of the actual surgical site, the dissection of an HPV tumor. This is your first warning. It's as bloody as one might imagine. And if that bothers you, I'm going to give a second warning right before that slide. So here we go. So this is the gentleman who came in. It hurts to swallow. How long has it been bothering you? Oh, a long, long time. Urgent care has given me a number of rounds of antibiotics, and it isn't getting better. Coughing up some blood on occasion, and this gentleman felt some hard nodules in his neck as well. So this obviously is a view. We're looking at the soft palate right here, extending down into this anterior tonsillar pillar and then beyond the scope of view. So if we then take a nasopharyngoscope, go in through one of the nostrils and look straight down. So here's base of tongue, epiglottis, trachea, and this is the mass. This is the tumor, an HPV-mediated oropharyngeal cancer. Here's a CT scan. Again, on the right-hand side of the patient, you can see the mass right here. You can see what it is already doing to the airway, beginning to impinge upon it. Here's one that is further down the neck, and you can see some lymph nodes that are, one would call, hot. As well, one can see how erratic this side, the right-hand side of the airway, has become as a result of this mass. So second warning, next two slides are pretty graphic, but very worthwhile. So here we are looking at the cervical site, anterior mandible, bisected through just distal to the canine, and then this right-hand aspect of the mandible has then been rotated up. Here is that cut line that used to be up against this portion of the mandible. One could see the premolar here that used to be right behind the canine, up into the mucosa. Tongue with the whole back portion of it missing, the tumor having been dissected out. One can see the nasotracheal tube right here going into the nose, and here it is passing over the soft palate down into the trachea. The dark areas all indicate cautery to control bleeding. When you look at this, wouldn't it have been a lot easier to have a vaccination and to prevent this from happening to begin with? And that, if there's a single pearl for the whole webinar today, it's let's just prevent this. Let's stop it now. Here we are beginning to rebuild. Here's that canine, the premolar that used to be up in the mucosa, the bisection, titanium plate here, holding everything together. Again, why don't we just prevent this? HPV comes in two different main categories: mucosal infections and cutaneous. The cutaneous, there's over 80 types, and these are your common hand and foot warts. What we're talking about today is the mucosal sites of infection, and there's over 40 types. HPV 16 and 18, those are the principal bad guys. They're the ones responsible for that tumor that you saw up above. That specifically was a HPV 16, when I say above the previous slide of the surgical case, as well as all of these other diseases. Lower risk, HPV 6 and 11, this is where your genital warts, papillomas, low-grade cervical disease come from, but this is a non-oncogenic type of virus. Most females and males will be infected with at least one type of the mucosal HPV at some point in their lives. Something like 79 million Americans are currently infected. There are 14 million new infections a year in the US, and they're most common in teens in their early 20s, and it has to do with sexual debut is the term that's used. First sexual activity, and the virus is shared. Most people never know they were infected. It clears on its own, no evidence, other than antibodies. Here's a slide that really has a lot of information in it, but to distill it down to the two things that I believe are the most important: cervical cancer in women and oropharyngeal cancer in men. Here is a contest that no one wants to be in, and the men are winning. There are more oropharyngeal cancers in men than cervical cancer in women. Women from the beginning of puberty are trained that they're going to get their annual exams, pap and pelvic, and it is entirely, the pap is entirely to detect HPV and its consequences in the cervix. And yet now there are more tumors in men, and there are no screening protocols in place. Breaking it down by sex, race, and ethnicity, talking specifically about the oropharyngeal cancer. And again, this is a contest that I don't think anybody wants to enter, but the men are winning this. It does happen, as the previous slide showed, it does happen in women, certainly, but what is just so disturbing is this explosion within the population of men. This is what's known as a cone biopsy because of the shape of the tissue that is removed. And the concept is that you're removing the infected and affected tissue of the cervix, and this is allowed to then granulate back in. This is something that would be detected on a pap smear, and it would be a positive, and then there would be a follow-up, and one of the options is then a cone biopsy. And again, nothing like this exists for oropharyngeal cancer. Here's a slide that summarizes some of the things we've just been talking about. The system for HPV detection is around cervical cancer and screening. Oropharyngeal cancer is now more common than cervical cancer, and yet we have no streamlined screening process. Oropharyngeal cancer incidences have exploded. And I'm sure you recognize this medical statistical term, exploded. But as you saw from the previous slides, how else do you describe it? HPV vaccine is cancer prevention. Some of you may be aware that when this was first rolled out, the HPV vaccine, it was done under the auspices of preventing a sexually transmitted disease from getting worse and causing cancer. And it flopped. Parents were upset with so my child's not sexually active. The marketing strategy bombed. They stepped back and realized HPV vaccine is cancer prevention. That's why you're doing it. Cancer prevention. You will run into parents, people who still have that old concept in their head, and you just simply say, it's cancer prevention. That's all it is. We'll get into some of the issues that parents bring up around the sexual activity question, but it is still cancer prevention. What is the vaccine? It's a virus-like particle that produces a profound antibody response, and such that it's higher than someone who has naturally had the infection. It is non-infectious, non-oncogenic. This thing's not alive. It's virus-like. It's a particle, and it's done with a recombinant process. What are the vaccines? Well, right now, the 9-valent is what's available, the Gardasil 9. It's important to know about the older ones. Let's start with the bivalent. It only had 2 of the HPV types that cause cancer in it. Later, the quadrivalent, which picked up the cutaneous affecting HPV, but did not do anything for these other less common varieties of HPV, but yet still causing 10% of cancers in the body. There will be patients who have had the bivalent years ago and maybe have been in a monogamous relationship and now we're back into the dating scene. They're not protected from the 2 here or the 4 here if all they got was the bivalent. And then you can also see the argument for the quadrivalent. You don't have this 10%. We'll get into the details of that here in a moment. Gardasil 9, that's the current one available. It's the 2 non-oncogenic strains, the cutaneous type, and then the 7 oncogenic strains that could actually cause cancer. These are no longer available, but to understand the history of it. When it was the vaccine was originally rolled out, the name was the Cervarix, and it kind of rhymes or sounds like cervix. It was only offered to girls because this is a cervical cancer issue. And found out very quickly that's not the case. Boys and girls equally need to have this vaccine. So the name changed, obviously. Gardasil 9 is the current. What is the recommendation? You can start as early as age 9. It's 2 doses if the first dose is given before the age of 15. This time frame right here, age 11 to 12, it's kind of a sweet spot. The response, the immunoresponse to this vaccine is very profound at this age. and only requiring 2 doses. Even if one were to wait later in life and do the 3 doses, the response with the 2 doses at this age is very profound and much bigger than a 3-dose regimen. Why do it here? 1, that response, and 2, parents still have a reasonable IQ in the minds of their children at this age. For those of us who have raised children, we know that as we get further along in these ages, mom and dad's IQ begins to drop rather quickly, may not have quite the control, busy schedules, etc. This is a sweet spot for a number of reasons. Just as we talked about it just a moment ago, summary of the vaccine recommendation. First dose, month 0, 1 to 2 month period for the second, and then the 3rd dose at the 6-month mark. The vaccination is just available and is recommended up to through, I should say, age 26. It's not recommended after 26. It is approved, however, 27 through 45. And again, if a patient's sexual life has changed or is changing, this might be something that could be talked about. Is someone in need of the most recent, the Gardasil 9, certainly there may be others coming out with even more protection, but say they got the bivalent at an earlier age. It certainly has less of a benefit because these people may have already been exposed to HPV. That's kind of a public health comment. Does it apply to the individual? Well, that individual, in conjunction with their care provider, can make that decision. Dosing schedules before the 15th birthday, 2 doses, 2nd dose administered somewhere between 6 and 12 months. That minimum of 6 months is important for the immune system to provide the response. Then for the 2nd dose to take it even higher. And then after the 15th birthday, we went through that already, but here's a graphic. How is it administered? It's an IM injection, the deltoid muscle, of course, aseptic technique, and hard to believe, but we do need to say a new needle and syringe for each injection. Key point here, to administer all of the vaccines that that child is due to have at the same time. Then they're all done. It's not a separate visit. It's not a separate set of issues. How is it stored? Refrigerator in the original packaging, so everybody knows what it is. Lids closed, labeled, and key thing, do not freeze the vaccine. Let's talk about the vaccine safety. So, and this is true for all vaccinations in the United States. There are 4 groups that monitor and follow what vaccine safety, reactions, problems. If you look at this, the PRISM group, 170 million individuals are in their database that are being followed. FDA is involved with 2 of these, CDC with 3. There is a lot of coverage here, a lot of data that is reviewed. I don't question the safety of the vaccine system that we have in the United States. Specifically with HPV, we've got well over 12 years, something like 18 at this point. They're safe. It's the usual kinds of issues, pain, redness, swelling in the arm where the shot was given. The fever, headache can occur. The one time that one would not give the vaccine is if someone is allergic to yeast. And yeast is the medium to grow out the virus-like particle. So that's why if there's an allergy to yeast. Like any kind of an injection, syncope is possible with the related jerking moments that can follow. But that's true with any injection, not just HPV. And here, recommendation is to be seated or lying down during vaccination, certainly lying down if there's a history of syncope with other injections. Had a patient day before yesterday that every trip into the dentist is lying down. He comes to the back and we lay him down because he's going to pass out. And that's not even when we're doing an injection. Hopefully the patient's honest with you, gives you that history if you don't have it already. It is safe. CDC and the FDA continue to monitor this. The safety profile, it has a good safety profile. Clinicians need to reassure parents who may have concerns as to whether or not this is safe. A lot of data to show that it is. What is the impact of the vaccine? Early outcomes, we see less of an HPV prevalence, lower rates of genital warts as more time goes on. The cervical disease, neoplasia, and precancers, and then in the decades that it takes to develop one of these oropharyngeal cancers, as well as some of the other body parts, a lowering of those cancers as well. It has had a huge impact. Lower prevalence of the actual vaccine, lower prevalence of genital warts, lower prevalence of cervical precancers. Here's a graphic to show you among women, two different age groups. The top one here, 21 to 24, and you can see that line is the kind of line you want to see with any vaccination or treatment. And then 18 to 20-year-olds, an equivalent slope. This thing works. This is a graphic that drives home the effect of this vaccine, maybe better than some of the others. Females, starting in 2004, the vaccine is administered, and you see this drop in genital warts in all three of these age categories, with the exception of 30, but it remains flat, over 30 that is. In males, without having gotten the vaccine, those rates drop also of genital warts. In other words, that HPV virus is not out in circulation, so the males are not exposed to it. Very dramatic. It appears to be very long lasting. Right now, the thought is that it's at least 10 years. Certainly to get through those early years, that 10-year time span gets one through that 18 to 28, 30 years of age when exposure is greatest. There are multiple studies to follow that. It may be that down the road, a titer would be taken for antibodies and a booster given if one is still sexually active, or as we spoke before, multiple partners, multiple new partners. It's effective, safe, provides long-lasting protection. As you talk about it with families, with parents, the benefits far outweigh any potential risks. You know, sore arm is nothing for that cancer that we saw at the beginning of this presentation. Let's just prevent it to begin with. We're doing the meningococcal vaccine, the Tdap. It's the steady findings show a safety profile that is the same. It works throughout the world. We drop HPV prevalence simply by the vaccination. Dropping the prevalence, stopping these cancers from starting to begin with. What more could you ask for? How do we frame the conversation? How do we talk about this? Look at vaccinations overall. If we look at the Tdap and meningococcal, you know, pretty high usage. And then you drop down into HPV, and it's much less as a percentage. We need to be talking about this. We need to be talking about a safety profile. Meningitis, you know, that's a bad thing. Diphtheria, that's a bad thing. Tetanus, but isn't one of these cancers a very bad thing as well? Cancer prevention, that's all we talk about with the HPV vaccine is cancer prevention. I think once we do, and that's our consistent message, that number is going to come up. All of these are going to come up. One of the things that is true with vaccinations overall, and certainly with COVID in the news, we've seen that nationally, that coverage is lower in rural areas consistently over time. What is interesting that in surveys, fewer parents in rural areas report receiving a recommendation for HPV vaccine from their provider. One could really get into the weeds on that as to why and how, but not today. Urban, 77% recommendation, rural, 70%. When a recommendation is given, vaccination coverage is higher. So, did you receive a recommendation? 78% yes, 22% no. That then converts to a 75% vaccination rate, as opposed to no recommendation was given, and look at the difference between 75 and 47. Huge. Parents of unvaccinated adolescents, top reasons for not starting the HPV vaccine series. So 10%, just with a recommendation, 10% could be removed from the unvaccinated. These other areas can be spoken to as well. The not sexually active, but they're going to be. You know, you put the seatbelt on before the accident. You don't even know that you're going to have an accident. You don't know who that child's partners are going to be, and you have no control over who they are. Very important that we do make the recommendation and make a strong one. Consistently, clinicians underestimate the value parents place on HPV vaccine. So on a scale of 1 to 10, all of these things are recommended through pertussis. Influenza drops off a bit, but look at HPV. That number needs to be this number. Consistently recommended. We think that it doesn't help, it doesn't push them to vaccinate their child. All the others say it does. The parents say that it would. We need to look at the perceived concerns and real concerns. If we have perceived concerns, maybe we're not going to recommend. Recommend and then see what their real concerns are. Let them ask questions. Much higher vaccination coverage when a recommendation was given. And then, as we know, moms make most of the healthcare decisions in families. In focus groups, they've said that they trust their child's clinician. This is something that needs to be done. Make the recommendation. What is an effective recommendation for HPV vaccine? Same way, same day. How you recommend other vaccinations, you recommend HPV as well. So, when you talk about Tdap and meningococcal, HPV is in that same sentence. And then, as they're talked about, all of them are given that same day. Same way, same day. So you talk about it as HPV cancers. And then I would suggest shut up. They have questions, they can ask questions. Very important that we get this recommendation across and that it's bundled in with the other recommendations. Here's a thought for a conversation. She's 11, she's due for 3 vaccines. It'll protect her from meningitis, HPV, cancers, and pertussis. We'll give those shots today. Simple. House Bill 2220 allows dentists to administer vaccines in the state of Oregon. I had the privilege of representing the Oregon Dental Association in front of the House Healthcare Committee to give testimony in support of HB 2220. This is a conversation that a dentist is going to have within their practice, whether it's a solo or a group. One could say that, sure, we can give the vaccine, But now we're involving medical insurance and a whole new scope of work. In my practice, we do quite a bit of hospital dentistry. My partner does sleep apnea. We have people who are very versed on medical insurance. They're very comfortable with it. Unless you have somebody in-house that is understanding of it, the sometimes slow reimbursement, it's something you really need to think twice about. Yes, it's legal to do, but is it fit within your business model? Why does my child need the HPV vaccine? So this is something that you can talk about in the dental practice. And again, I ask you to refer back to that surgical case. It prevents cancer. So you make a recommendation. If you're not doing vaccines, you have a relationship with the primary care providers, with the pediatricians in the area, phone numbers, a brochure with the phone numbers, something to hand to mom that says, this is important, get it scheduled. Maybe even the front desk schedules it for them as they leave the office, as they are leaving the office, rather. We've discussed this, cancers of the throat and genitals, and it's important here for many, many people, they still think of this as a female vaccine. And as you've seen, no, that's not the case. It's now even more for men. So the boys and the girls need to be vaccinated, and that needs to be talked about. Yes, they are at risk. And again, no parent controls who their child's partner is. No control there. And so there will be exposure most likely. We've talked about this as well. 11 or 12 years old gives us the most robust response. It's kind of a sweet spot. Most control over the child, their schedule. Mom and dad are still fairly smart. And when do you put that bike helmet on anyway? After the car hits them? You do it ahead of time, before they're sexually active. What do you tell parents who think their kids don't need the HPV vaccine at age 11 or 12? Well, one response for the parents is, well, my kid's not sexually active yet, or they're not even thinking about sex. And so an answer is, oh my gosh, that's fantastic. And they look at you kind of strange and you say, yeah, let's catch it now so that when that does happen, sexual activity, they're covered. It's done. Because again, that parent has no control.
For me, this is the moment where I actually start asking questions. And so you sort of pause for a moment and you ask the parent, so tell me more about that. So I'm hearing you saying that you don't want to give the vaccine. Is there something in particular that is making you think he doesn't need it? Or, why do you think your child doesn't need it? And let them explain sort of more about where they're coming from and what their position is. And then it really helps me to answer their questions or to figure out where I might be able to help redirect them to understand a little bit differently where I'm coming from. The most common one I've heard is, my kid's not sexually active yet, or they're not thinking about sex. And my answer to that is, oh my gosh, it's fantastic. They sort of look at me a little bit strange because they're like, why are you excited about that? You're like, well, I'm excited about it because vaccines are something that you want to give before something happens. And so the fact that they haven't started having sex is perfect because it means that we have time to get in both doses of the HPV vaccine before they're ever exposed, which means it's that much more likely that it's going to protect them against cancer. And for most parents, that's enough to sort of flip the switch a little bit and change their mind.
Couldn't have been said better. Catch it before it happens. The 2-dose schedule is recommended before the 15th birthday. Again, to start that today. So are you giving vaccines in the dental office? That's an individual decision that a dentist needs to make, needs to think about. If you're not, which I would suggest that most are not going to be, other than maybe some large group practices, Do you have some kind of a connection, a vehicle by which to get that child into their primary care provider? If you're giving vaccines, there's your question. Both my children have had the HPV vaccine. It's endorsed by any group you want to talk about. That it's very, very important. We have a unique opportunity as dentists. We see patients on a consistent basis, and there's a relationship that develops there that we can make these recommendations. Train your staff so they have the answers. I will tell you that when I was at OHSU for 4 years and was part of the cancer reconstruction team, casual conversation with somebody on staff up there, they noticed that vaccine rates had dropped in a primary care clinic. Vaccines were literally stacking up in the refrigerator. And what is going on? Long story short, there was a person at the front desk who was an anti-vaxxer and was making sure that everybody came in, heard about it, and gave just enough information to muddy the water, and parents were walking away without vaccinating children in a significant enough percentage that it was noticed. Well, that person was certainly reassigned to a different area of healthcare. Make sure your team is up to speed and understands why and how. Everyone's at risk for oropharyngeal cancer. This is not your traditional type of head and neck cancer. It's not the smoker drinker. I saw a lot of that at OHSU, but we saw an awful lot of HPV-mediated oropharyngeal cancer. By no means are all of these tumors treated with the type of surgery that you saw in the first couple of slides there. Most are treated with radiation, and they can use that 4-letter word, cure, with that treatment. But oh my gosh, the morbidity. It is not a fun procedure. Public health in general, they want dentists involved in this. We play a big role. We see these people, we're comfortable in the oral cavity. You know, we can have them say ah and stretch open that soft palate and look beyond the posterior tonsillar pillars. If we see something, you know, ulcerated, white, red, then with further questioning, how long have you had a sore throat? Then maybe we're into the neck, submandibular areas, looking for those hard fixed nodules, lymph nodes. Then a referral is made. Again, as was said at the beginning, have that relationship on the front end, either with ENT or OMS, whoever you're comfortable with, somebody to then get the biopsy done and a referral is made that's appropriate. The surgery slides were provided by Dr. Dan Petrusor, who is an OMS at OHSU. He's also in private practice in the, I believe, Tualatin area. He is a dual degree, but he did a fellowship in head and neck oncology surgery as well as free flap surgery. This is the kind of thing that he sees day in, day out. Do you have a relationship with someone who can do that initial biopsy and get the patient into a Dr. Petrusor's hands or whoever is chosen, just so it happens as cleanly as possible? Plan ahead. How are you going to do it? Beat this one pretty hard here to say cancer prevention, HPV vaccine is prevention, as opposed to the treatment and all that's involved with that. Pretty simple math. Have brochures out, have a practice philosophy, make sure everyone's trained on how to approach HPV and oral cancer in the discussions. And the vaccine. Add sections to your patient questionnaire about HPV vaccine history. Get the conversation started. Talking points are available from the CDC that can give you a flowchart as to how to speak to patients, give you some ideas. Actions at a glance. Know your unique role. We're in the oral cavity. We're seeing people on a consistent basis. Talk about cancer prevention, which is vaccinations. Collaborate with whoever's appropriate to provide those vaccines. Collaborate with your team members in the office to engage in that conversation. Again, more brochures and information from CDC on HPV. Keep all staff on the same page. Very important. There are a lot of education products out there, immunization courses, conferences, all kinds of CE available, and there'll be more and more as awareness of oropharyngeal cancer, HPV-mediated oropharyngeal cancer becomes known. It's sadly a blossoming area. Stay up to speed. It is a changing landscape. HPV vaccine is cancer prevention. You are the key. You can play a role in preventing this cancer from ever happening. If it does, early recognition. Thank you so much for your time. That's what we have today.
Thank you so much, Dr. Hagerty, for sharing your experience and your expertise with us today. Some items to keep in mind while you write comments or questions. Again, just a reminder, use the questions menu. It's at the bottom of the control panel. We'll try to answer them all. So reminders, please claim your certificate to complete the program evaluation. It'll take just a moment and will be of great help to us. Remember, the activity code expires in 1 week. I'll show it to you in a second. Again, the webinar is being recorded and will be available on our YouTube channel. You will receive the link via email. Feel free to reach out to me or our office if you have any questions or concerns. We'll be happy to be of assistance. And in about 2 hours after the webinar, we will email you the instructions on how to get your certificate and how to watch our recorded videos via our YouTube channel. Here is the activity code. Please write it down. And let's see if we can find any comments or questions. And I don't see. Okay. Seems that other attendees have understood everything, and we don't have questions. But if for any reason you come up with a question later on, feel free to send it to me, and I'll make sure Dr. Hagerty answers it for you. Okay, so now, again, write your activity code over here. And now, thanks to our speaker for sharing his time and knowledge with us, and thanks to all of you for participating today. Email me if you have any questions, and you have now completed the session and you may disconnect. Have a great day. Goodbye.